Okay, we're recording.
Great. Good morning, everyone. Call this Assembly Health Policy Committee to order. It's Wednesday, August 5th. Carissa, can you do the roll call, please?
Yes. Ms. LaFrance?
Here.
Ms. Quinn Davidson?
Here.
Ms. Allard? Mr. Constant?
Here.
Mr. Dunbar?
Here.
Mr. Rivera?
Present.
Ms. Zolotel?
Here.
Okay, thank you.
Excellent. Thanks, everyone, for attending. Good morning. We'll start with item 3A. We'll hear an AHD update from Director Pineda, and this will be the last AHD update we hear from Director Pineda.
It is true. This is my last update. I'm wondering if I can share my screen or if it needs to stay on the agenda. Do I need to request control? Oh, you gave it to me. So simple.
Yeah,
well,
that's great. Go ahead and share your screen. Thanks, Natasha.
Okay. Screen 2. Okay, so you guys should be able to hopefully see a PowerPoint. I wanted to show you guys a couple of different things on the dashboard as well. So I'm going to move between both the PowerPoint and the dashboards. So I'm just going to scroll down. Sorry for any technical bits. Okay, department update. So my last day will be September 4th. Heather Harris starts on August 24th. She will have some time crossover. I extended my last day so that we could have some crossover time. We're working on a transition plan, and I'm sure that the administration will work with all of you on, I think there's like, you guys grill the department heads before you approve them. So I don't know if how you guys will schedule that, but she'll be joining us soon, and we're looking forward to that. Last time I reported, we are working on a policy statement around racism as a public health crisis, but it has gotten a little delayed because we had an unprecedented number of COVID cases that really took over our whole world for a period of time. But I am still hoping to finish up that policy statement before I go. That is a personal goal of mine. As some of you know, because you've had lots of email traffic, and so have I from you, we've been working on some unfinished animal control code changes that were requested to be reviewed. So you'll probably continue to see that ongoing. Childcare licensing still has stuff to do, but we have not brought that forward. And the cemetery has still waiting like 3 years later for their code revisions. So that is going to be on the list of the next director to move forward. The cemetery, not too much to highlight recently, except for the very big news that the bell tower is completed. So you've probably heard it. If you spend any time downtown, and you're welcome to visit that. It was a long project that they worked on, and I'm sure they were greatly disappointed not to have a grand opening, but it is completed and it is working. The administrative division has really been focused on completing all of our closeouts, so all of our grant closeouts, all of our new grants starting, so they have just been incredibly busy with that. The RFP for the Adverse Childhood Experiences grant that the Assembly provided us resources for should be making its way to the Assembly for approval. So the proposals have been evaluated and a grantee was selected, and that award should be coming to you, I think, in the next meeting. I didn't get a chance to check. We were informed on July 28th that the Alaska State Troopers will not be granting the municipality any money this year to reimburse Providence's SART program for the forensics exams that they complete for the police department. Typically, we were receiving around $50,000 to $70,000 a year, and that will no longer be a resource available to the police department or SART. So that's something to note. Human Services Community Matching grants were already approved at the last Assembly meeting, so you already know about that. Emergency preparedness. We have a new emergency preparedness manager who started on August 4th. Her name is Kelly Byastock, and she is currently in her onboarding process, learning all the things that we have going on. So she is joined with a new emergency preparedness administrative specialist. Both of those positions kind of came on right around the same time. So those two will both be jumping straight into emergency COVID response while also learning the ropes here at the health department. The emergency preparedness team is preparing for what would be needed in a mass distribution situation for a potential vaccine. They recently did a presentation to the administration around what that might look like. You probably have heard the news that we have 5 new testing sites that are up and running. That was launched through the public health branch of the Emergency Operations Center. So there's 5 new locations and mobile testing services that have proven to just be really critical. So when we have notice of of somebody who has been positive in congregate setting, we're able to call the team over there, and they're able to deploy a testing team to get out and get everyone in the potential exposure location tested. So that's just been a really big game changer for us just in the last week. We've utilized it multiple times. So very good news on the emergency preparedness team side. For Human Services Division, I got a few brief updates. Childcare licensing, we still have 60 closed facilities out of our 239. Let's see, 25% of those are licensed facilities. 87% were planned closures and 12 are closed due to COVID-19. So they're tracking that pretty closely. They have provided us with really specific details about why programs are closed. A lot of the programs that are closed were summer program, were school-aged year-round, like school year programs. So that's why they were closed. But if you want more detail, we can provide that. The program to distribute funds to the facilities is open and applications are flowing in. I think the last I looked, they had well over 100. So there's more to come on that. It's going well so far in terms of the process of getting the applications in. The Community Safety and Development Program, which is the HUD program, has been under an audit for feels like a couple of months. They've finally finished that audit, which is exciting. For the Community Development Block Grant Program. And you'll start to see some memos coming to the Assembly for approval for action with the Community Development Program. They should have all of the information in there to help you navigate your review. But again, we always want to be a resource, so if you have questions, please send them to us. Emergency Family Shelter Network, nothing really, it's the same report as last month. We're still using the guest house for families and using the mass care unit at the EOC to manage and look at what our needs are going to be going forward. The Safety Patrol had an uptick in calls during the month of June. They responded to 2,150 calls, completed 756 transports, and performed 899 intakes. You might have seen in the news, the senior centers, they did a fun kind of morale boosting activity at the Chugach Manor and View, where they had a line of classic cars, and the Corvette Association of Anchorage rolled through there and did a socially distanced, safe entertainment for the seniors. That was kind of our positive note. I'm going to do the community health nursing update last, just so I can walk you guys through the dashboard. Environmental health services. Some of you have reached out to kind of better understand how we're continuing to do our work. We are being as innovative as possible to keep workflow moving, to do inspections electronically and remotely, and continuing to do, all of the work that needs to be done. We do have 3 of our staff of the environmental health team are assigned to the EOC or to the public health work here at the health department. So they are a little bit of a shrunk team, but mostly still doing the job of environmental health. So I'm going to just do a little brief update on community health nursing. You'll see, I'm just going to walk through the state just updated their dashboard, and I know that I have walked through with some of you how to use them, but since it's updated, I think it'd be really good for you to know. Something to note is that in the month of June, so the last time I talked to you all, we had a total of 219 coronavirus cases that we had to do. contact investigation and monitoring for. And in the month of July, we had 1,277. So it was just for the work that we were prepared to do, it was pretty explosive growth. And we had quite a lot of cases. In addition, our department continues to work with a large number of clients who are either need to be screened and monitored for tuberculosis, syphilis, and other infectious diseases, which on the countrywide situation are on the rise. And we think that will be the same issue here. One thing that we're working very hard to do is moving to this cloud-based COVID case management tool along with the state so that we can bring on new public health nursing resources and free up our traditional public health resources to continue to do the important infectious disease work so that we don't create another problem by trying to address COVID-19. So really quickly, I'm going to jump over here to the state's dashboard and just show you. Many of you have probably come here, you go to the alaska.gov, you hit the COVID-19 button, and you click this button and it will take you directly to this new website. And I wanted to show it to you because I know a lot of you have asked me questions about different kinds of data that we have, but we haven't necessarily had an epidemiologist to do the work around. So for now, we're still going to rely on the state's dashboard for some things. So you can come over here, you can toggle in-state or out-of-state. You can pick residents or non-residents. I've picked in-state residents for Anchorage. And this is what the screen looks like. So you can kind of see down here, the confirmed cases, have been really manageable, and then they become unmanageable. Now that doesn't mean that in the future, with all of the different resources online, that this level of activity might be it may be manageable when we have 500 contact tracers statewide that can all jump in and help at different outbreaks. But for this month, that just wasn't the case. So this is where we saw, 50% of our cases. We've had a total of 1,933. We're about to hit that benchmark of 2,000. Each day, this updates with new cases. You can see that we have active cases of 1,360. So those are 1,300 people that we need to contact on a regular basis and have interviewed and done all that work with. This shows the recovered amount, so our recovered numbers are 560. Over here is a new tool that I don't think this was available in the old version. So you can see the age range of the distribution of cases, and you might see this change over time. What we've seen nationally is that this first hill we're going up, you get a lot of young people, and then as they go out to their workplaces, families, and other locations, the numbers might shift to older demographics as it spreads. You can see the gender breakdown is pretty even, and then race. So this is one you guys have asked me a lot about. So this is for Anchorage. As you can see, a large number of our total cases are still under investigation. And what that means essentially is that when the lab came in, it didn't have the race listed on it. And so our staff have to acquire that information and then go put it into a database. So this might take a while for it to get caught up. But what this doesn't show you is the percent of the population. So for example, it looks like it would be important, and we'll be working with our new epidemiologist, who we are recently just hired one, to actually do the percent of the population that we have here for these different groups, and then the percent of the burden to show where there's disparity, because there's certainly disparity growing in how COVID is moving throughout our community. So this is something you can go look at until we get ours dialed in and can give you more detailed reports. This is the best for now. It also has ethnicity. So then the other place you can look for information is our municipal website. So some of you may have made your way here to this roadmap to reopening, and then there's the matrix red light, green light situation. You click onto that and you can come in here. There's one new chart that I wanted to show everyone. Tina Miller with GIS was able to create a chart that helps us watch, this is the hospitalized patients in Anchorage, and that's a lagging indicator. So what that means is that, that's usually 3 to 4 weeks behind the current caseloads. But a new way that you can look at it too is be able to see positive patients versus discharged patients. So yesterday we had 23 positive patients in the hospital in Anchorage that were residents of Anchorage, and 1 discharged patient. This doesn't show people who are from out of the community. And then down here we added this so you can kind of see as we have deaths. A lot of times I think those just kind of get washed out in the news, and I wanted just a better way to see what the trends were with deaths. So she added them in here. So that's a tool that you can use and look at. And that is all I have for today on the report.
Thanks so much, Director Pineda. Really useful website. A good reminder that we can go there. I have a question from, I want to note for the record that Ms. Allard has joined us. She's just by phone. And Mr. Constant has a question.
Yeah, and not a question, actually. I just have to state into the record now for the first time that I will not be able to participate in the confirmation hearings for Heather. I currently have an open real estate transaction as a referred agent to her husband, Josh Harris, and there's an active purchase and sale agreement on the table. So I will need to be not involved in that process at all.
Thanks for letting us know, Mr. Constant. Ms. LaFrance?
Thank you, Madam Chair. And Ms. Pineda, thank you for that update. I was wondering if you could go back to the comment about the sexual assault response team funding from the troopers, and if you had
Sure.
any more information, any proposals for filling the gap, and will the troopers still be involved in the team outreach or the program? Thanks.
That's a great question. I don't believe that they were not going to participate. You mean in the AISIP? I don't believe they're not going to participate in that. I think what they're not going to do anymore is pass through any funds for SART kits, for any of that forensic work that they've done in the past. But I can find out if they're planning on also not participating in the coordinated effort to address domestic violence through orders.
Thank you, and thank you, Madam Chair.
Yeah, of course. I want to note for the record that Mr. Weddleton is also on the phone with us. I'm going to go to Mr. Dunbar first, and then Mr. Weddleton has a question as well.
Thank you, Madam Chair. Ms. Pineda, could you restate where to find that demographic information on the state website? So I'm looking at the ArcGIS site here, and is it through that tab, or is it through a different one?
So that for the state one?
Uh-huh.
Let me just pull up my screen and I'll walk you verbally through it. So what I do is I go to alaska.gov. I'm just going to do it while we're live. So for the state one, go to alaska.gov, click on coronavirus.alaska.gov. Here, there's that red alert box.
Mm-hmm.
Click on that. And that will take you to the COVID-19 Alaska page. I scroll down. And then I click on this blue highlighted section under the latest COVID-19 data and say view detailed data at the DHHS Coronavirus Response Data Hub. And sometimes it takes a little while to load. But we will be loading the local demographics into our local page once we have a little time. This just went live yesterday. The other thing we'll do while this is loading, we have been able to secure an epidemiologist, which is really exciting, and she starts on Monday, and we'll start working on developing reports, like really detailed reports that we can give to different communities that might be being impacted differently by different outbreaks in more real time than we've been able to do so far. So then you get to this web page, you have to go to the right here, the left of the page, and you have to select your region, and you can select any region in the state. Sometimes it takes a little while to load. I'm just going to look at in-state. You click here and you're going to pick the municipality of Anchorage. The nice thing when you're looking at all of it, you can see that we're not the only community that's in the zone. Actually, let me go back and just show you that. All available. So when you look at all available and you look at this alert level map, this alert level map shows you that the interior is also experiencing red levels. A lot of the other parts of Alaska are in orange, and some are in yellow. And that is informed by these 7-day rates where you can kind of go click and find the rates if you want. I mean, you have to spend a little time digging. We're hoping that the epidemiologist will be able to provide you guys with, and with the administration, better reporting in the weekly report that we send to you. So I pick Anchorage municipality, and then it will change all the graphs to just be for Anchorage. So everything now is just Anchorage level data. And you can look at onset date, report date, how people are getting sick, how many people are hospitalized and when. There's quite a lot of data in here. And then the way to get to the local municipal data is a similar method. You go to muni.org.
Oh, but I'm sorry, Ms. Pineda,
Yeah.
you were talking about demographic data though?
Oh,
Where-
yeah.
Where in that chart is the demographic
So you
data?
go to the statewide cases by age group. And then you go to, you can look at age, gender, race, or ethnicity. So when you look at race, for example, you can already see that 437 of the cases out of 1,933 are Alaska Native. And that's obviously disproportionate to the population that lives here in our community. So what we're going to work on is getting a graph that shows this with the proportion of the population. So if Native Hawaiian and Pacific Islanders make up 3% of the population, but they make up 6% of the cases, then that's a disproportionate impact. So we'll be able to start communicating that in a concrete way. Right now, it's been very informal, where we see an outbreak in a particular population or a part of town, and we're able to work with that community group or leaders to address our concerns and try to help keep that community healthy. But now we'll actually be able to distribute really concrete data that should help inform the local activity.
Great, thank you very much.
No problem. So you guys know how to get to the Muni one? Have you guys all gone here and clicked the COVID-19 update button?
I think so, yeah.
Okay.
Is there
And
a
I-
question about
I'll
it?
do that again.
Mr. Weddleton has a question. After that, Ms. Salatel. Mr. Weddleton, you might be on mute. Let's go ahead and go to Ms. Salatel, and then we'll see if Mr. Weddleton pops back in. And as a reminder to people on the phone, *6 to unmute.
Can you hear me okay?
Oh, yep, we can. Go ahead.
Okay, yeah, sorry about that. *6, not #6. Yeah, question, and I got in a little bit late, so correct me if I'm wrong, but so we have obviously increasing number of cases, COVID-19 in town, and that's concerning. And when I look at our city dashboard, the thing that has the most red is under what I think of as contact tracing. So is that really what's flipped us into the kind of shutdown for the restaurants and the bars, is because we're just not able to keep up with the contact tracing?
No, it's I think what happened that's the most important to note is that we had a really multiple significant outbreaks that were large in nature. So, 72 multiple outbreaks that caused pretty significant community spread, which moved our risk alert level to red. So I tried to describe it in the weekly report, but both the White House and the state have established these risk alert levels. And at the time, I don't believe, we're way beyond the red zone in terms of community spread. So what you're seeing, a week ago was from 2 weeks ago, the spread. So that means if we're at an R0 of 1.3, there's that many more people every day infecting each other through exposures in different locations. And it takes, 14 days for it to incubate. And then 14 days later, we're seeing all of these cases popping up where they got it in a community acquired location, and then they brought it to the senior assisted living home they work in, or the congregate situation that they live in, and then it starts to spread in those places. And in order for that to get under control, you just need a little tamp down, so that we recognize we're not eliminating COVID, but what we can do is make it manageable as possible. So in all other places around the country where you start to see that move into that high risk level, that's an indicator that you need to make a shift pretty quickly. We also started to see a rapid, in comparison to the number of deaths, we've had quite a few deaths in the last week that were concerning. So it's starting to get to more vulnerable populations. So the state's CommCare system that we've all been working together towards, which will actually move most of that public health capacity back into yellow, is pretty much on board. Today is the first day of like full implementation, where our nurses are fully in the system now, all trained in the system and deploying cases through that system. And we think it will rapidly move through the backlog of cases and doing basic index interviews, and then hopefully get back to doing more comprehensive contact tracing, where you actually talk to an individual, find out who all their contacts were, and then communicate with all of those. Right now, we're not even doing that level of investigation anymore because there was just too many cases. There's, over 1,000 cases in a 30-day period was too many for our team to communicate with. But it's looking good, and we're pretty excited about the new asset that's coming online.
Can I follow up a bit?
Yeah, of course, Mr. Weddleton.
So how many contact tracers would maybe be optimal or would be needed now to deal with all these new cases? And if we were able to do that contact tracing, would we not have to close down, the bars, restaurants, and so on?
Yeah, I think it just depends. We have a couple of reports that indicated it just depends on what kind of contact tracing that you're doing. So the state and we all agreed. And when we make these decisions in public health, we're making them in concert with the state. So we're meeting with our state partners in epidemiology, Dr. Zink, that whole crew, and we're looking at the situation on the ground, and we're making a determination about how can we, our team, along with their team, address this, because when we have this many cases in one community, it obviously impacts the state as well. So the goal is to have 500 contact tracers statewide in the CommCare system, and they're working on bringing those on. We'll probably max out at 50. I can show you, I can't do it right this moment, but there's an actual projector where you plug in your population, and then it tells you how many contact tracers you need. Those are based on the traditional version that we had been doing at the very beginning, which is like almost takes about 3 hours per person. We call you, we find out who all your contacts were, and then we call all of those people. But we've moved away from that 3-hour version, and it's it's a shorter interview now. So that changes like the quantity of people you need. But we did request 7 more public health nurses and the supervisor and administrative support to help cover the load that we need to care for in our local jurisdiction. We're hoping that will be enough.
And so is enough, if you got that and you could trace all the contacts, then do we not need to close down?
If you can, it's not just one piece that matters. So maybe we can call everybody that's getting sick, but you're having, overrun. Maybe we get to a point in 40 days or 30 days where your hospitals are overrun. Well, that's a reason that you might make a closure decision or a different policy decision, because it's impacting a different part of the system. So as we went red in public health capacity, that's where everybody put all the energy into fixing that problem and bringing that on. But that doesn't necessarily mean that in December, if the hospitals are shut down because they have too many cases because we did nothing to stop the spread in our vulnerable populations, then you're going to have another reason to close down, right? So there's a bunch of different levers. I think Dr. Zink talks about it really well. There's bunches of different ways that you have to address things as they're happening. So hopefully, this tamp down gets us where we need to be, and you don't ever have another flare up, because everybody understands that this is serious and it is moving to vulnerable people, and residents of our community are having negative health outcomes from it. that would be ideal if that stopped, right? And that we don't have to make any of those hard calls anymore.
You sound very optimistic.
I mean, I'm hopeful.
Great. Thank you. That helps a lot. Thanks.
Yeah.
Thanks, Mr. Weddleton. Ms. Salatel?
Thanks, Madam Chair. Mr. Weddleton got to a lot of the questions. I thought you might catch the last one I had, which is this one has come up a few times in my email. So I thought I'd ask, and if you need to defer, that's totally fine. But what's the discussion or ability to bring on more ICU or hospital capacity? Because that's one of the arguments I'm receiving to say, why aren't we investing in that instead of doing more restrictive measures? And I understand everything doesn't stand alone, but if you could provide any context for that, that'd be great.
Yeah. So that's what we did during the first, one of the main things that happened right during the first closures was this development of more capacity. So you have all of this capacity available, built out in the Alaska Airlines Center, so the alternative care site. You have hospitals that are more prepared. They were able to do all the things that they needed to do to rethink how they do their business and bring people in and care for them. In addition, a lot of things that have happened around the country we're learning more about the disease. You have better ways of managing some early issues for people. So those things just didn't exist in the first round of impacts. However, what you still have here is a finite workforce. So you might have 148 vents available in Anchorage, but do you have enough employees to actually manage those vents? Those are called vent techs. There's a really specific kind of group of people that know how to do that. So that's the next area that I believe the EOC is going to be looking at, is actually staffing. So just because you have all these beds doesn't mean you have staff to manage them. So it would still be foolish to just go, it's okay, let's just let this run rampant in our community. We know it's going to really negatively impact some very specific populations who have a higher chronic disease burden, and we're just going to let it go because we have enough beds in the Alaska Airlines Center, but we actually don't have enough staff. So that's what the hospitals and the state have been continuing to work on, like what would the staffing look like. But you'll probably start to see, I think, Bill, if he's not on here, I know the EOC has started to work on what kind of staffing is actually available, because that's a pretty big hole. There's only a certain amount here.
Perfect, thank you. And I'd also emailed the same question to Bill, so I appreciate the answer.
I think he has a better answer than I do, but that's the general thing. When we talk to the hospitals, like those are the things they're thinking of. There was a belief at one point that there was this big statewide group that could just, you could call on them to come staff it. And as they started calling through all the people that had signed up to help, they'd either moved or they'd gone back to their regular job, because early on when everything was closed down, people were laid off. A lot of medical professionals weren't working. So then you could pull them in to do that work. Anyway.
Thank you, very informative. Yeah,
Mm-hmm.
Thanks.
Thanks, everyone, for all the questions. This is great. I have another one from Mr. Dunbar, and then we'll go to Ms. Allard.
I think Chris has a follow-up to that one if he wants to jump the line real quickly, if you'll let him.
Sure, Chris, go ahead.
Yeah, it's very brief. Natasha, I think what I understood from what you just said is that staffing piece is super important. Does that mean we can anticipate that being one of the graphs going forward in the dashboard once we understand the staffing levels we need? Because that too could be something that really helps the public understand the critical nature of the problem.
Yeah, I don't know how it's just been a recent conversation that I've been popped into, but that they might be farther along or less farther along. So I defer to the EOC on how they will quantify that information and how it would be used.
Yeah, and so I guess I just would ask they come up with a benchmark to show in the dashboard.
Yeah.
Mr. Dunbar?
Thank you. And Ms. Zolotel's specific question from a constituent reminded me that another constituent had asked me to ask a question. And I apologize if this is not your account, if perhaps this answer is better delivered by someone else like the EOC. But they were wondering what the thinking was behind the emergency order preventing bars and breweries, or maybe it was just bars, from having the outdoor service, but allowing restaurants to have the outdoor service. What's the distinction there?
Oh yeah, I don't have that answer right at my fingertips, but certainly I'd email that one to, you can email it to me and then I'll forward it to the the right group, or you can just send it to Jason.
Okay, I will do. Thank you.
Thanks, Mr. Dunbar. Ms. Allard? *6 if you're muted.
Okay. So thank you, Ms. Padilla. So I have a couple of questions, and I don't know if you guys have answers right offhand. But working with FEMA and with the Army Corps of Engineers in regards to the beds, this is going back to where Meg had her question and follow up. My concern is that I was told that the beds, we could develop more beds, obviously, because FEMA is involved and the Army Corps of Engineers to get those beds made. But my other thing was I was told by the Department of Military and Veterans Affairs that these beds, where you said we might have less staffing available. My question is, my thought is, they told me that those beds would be for people who didn't have COVID. So individuals that were sick at the hospital would actually be the ones that would be in the Alaska Airlines Center. And then those who had COVID or were sick would be in the ICU units, and they would have the care that they needed. Is that not what we are doing as the MOA? Or do we have a different plan on that?
I think Bill has joined us and he can probably answer it best, but my understanding was, and it's been a while since I've been engaged in that conversation, is that yes, you are correct. The purpose of building out the extra beds was so that you could have a place for people who were low acuity or had less medical needs, but still needed medical support to be in those locations so that you could free up even more space in a hospital to provide the level of care that somebody might need that was more ICU level. I don't think that's changed, but I do think there will continue to be staffing concerns if we were fully overrun, but I'll let Bill Falsey add anything that he might to that question. Bill, did you hear the question? I see his little shape there.
Can I just say, because I was told we do have adequate care available for those and that we have enough staffing, and I'm hearing the MOA say something completely different than the state level and the federal level. So it worries me a little bit that we're putting that information out, but I'm getting different information. And maybe Bill can just clarify.
Yeah, or we can have clarification from the hospitals, because they're the ones, the state and the hospital I think are running the alternative care site if we need it. And those are just based on the conversations that we've had. But if you want something official, we can work with Bill and make sure that that happens for you.
Yeah, Natasha,
Thank you. I appreciate it.
Yeah. Oh, sorry, Ms. Allard, to interrupt you. I don't think Bill is on. So would you work with Bill and the hospitals, whoever, to get some of that information and circulate it to the members?
Yeah.
Great. Thank you, Natasha.
Thank you. I appreciate it.
No problem.
If we don't have any other questions, I think it's time to move on to our next item in the agenda. And both items 3B and C, I think, can be somewhat quick. Our intent, 3B is alcohol tax discussion. We've been talking about this extensively. We just wanted to give Natasha a chance to, if she wanted to summarize or leave any parting thoughts. Of course, the health department did report that made suggestions related to the alcohol tax. So there's an opportunity to do that. And when we get to 3C, it'll essentially be the same. We had a report that she'll probably summarize it was probably a year and a half ago now with priorities. We just wanted to take a poll of where we are on those priorities and what might be left that we can carry on Natasha's legacy after she leaves. So with that, go ahead, Natasha.
Sure. So I put together I tried to make my point very small. With the alcohol tax funds, my suggestion from the very beginning of even before the alcohol tax passed was that it would be ideal and it is best practice to set aside a certain percentage of the total tax, regardless of the amount, every year for prevention. So I'd love 25%, I'd live with 20. It's something that would be a game changer in Anchorage, where we really don't have a strong prevention infrastructure that's invested in by the municipality. I believe from my many years of experience and also from best practices from the CDC and the states and all the different ways that money goes out, that those funds should be distributed through competitive outcome-based grants to community providers and schools. I'm going to describe what I mean by that, but mainly the point is that instead of kind of cherry picking programs or groups that are good at lobbying what they want from different folks, that the administration and the assembly really say, hey, here are the goals and here are the parts of our community that we want this to go in, or the way we want it distributed throughout the municipality. Give that instruction to the health department and say, we want to achieve these goals and we want to make sure that it's spread throughout the communities, and then have the department actually go through a competitive process that's made available to the public for them to get to those resources. So it's not, I know historically that I've been asked to give very specific things that we want it to be spent on. So then I went ahead and gave you if in a best case scenario, here's a potential breakdown of how I would spend it. Let's say the first year or whatever, we got, 2.8 million total. Let's say I just kind of guesstimated that's the percentage that year. I would put half of it to evidence-based grants to providers that would go out specifically to achieve a goal. So in this case, I am recommending addressing adverse childhood experiences throughout the whole municipality, and that we would use the evidence that's available to us through research to design that request for proposals to go out in a way that's fair and equitable. And then the other half go to early childhood education grants or early education grants. The reason why I feel like that's the best use of prevention funds is that it builds and expands on the work that you've already indicated was important related to preventing child abuse and domestic violence. It's also evidence informed and is supported by lots and lots and lots of research over the last 30 to 40 years about how best to deliver prevention at the community level. I would love it to benefit children and adolescents from pre-K age to the 12th grade. And as a department, we think that it would be really important to have targeted efforts, if possible, that specifically provide resources to parts of our municipality that have high rates of reported child maltreatment and high health equity index rankings. And then just as a quick reminder, when I'm talking about prevention, I mean 3 different things. There's primary prevention, secondary prevention, and tertiary prevention. I know you guys have already heard all this before, but I thought I'd put it in here so that the slides would, if you go back and look at it, that you can refresh your memories, and there's the links to all those resources there. And that is how I would love to see the prevention dollars invested.
Great, thanks, Natasha. I have a quick question, and then Ms. Saltel's in the queue. So this actually mirrors what, I'm not sure if we even told you, but the Health Policy Committee and the Homelessness Committee jointly put together a proposal that we presented at a town hall last night, and we'll do so again tomorrow. And our breakdown was basically half of the prevention dollars for early childhood ed and half for these evidence-based grants. We, however, suggested a higher level of funding that's more akin to a third-ish, maybe a little bit more than a third. So yeah, I guess my question is, you put 20 to 25%. I'm actually surprised to see that it's not higher. Were you just hoping for the best you can get, or is there a reason that you set that amount?
Because I've been working in prevention for 20 years in Alaska, and it's usually like the very last thing, and maybe you get 10%. So I was shooting high with my 25, but I'd love it to be 50, but I'll take 30.
Okay, that's helpful. Ms. Alto?
Thank you, Madam Chair. So this is great. Yeah, as Ms. Quinn Davidson indicated, I think we're in like the 30 to 40% range. We're getting there. But all of these evidence-based grants will require probably some health department staff. And excuse me, we'd put aside a $300,000 line item across kind of the whole alcohol tax for AHD staff. But I'd like to get a little bit of a reality check on that, because I think when we're talking about evidence-based grants and outcome driven process that is competitive. I really like the competitive nature of what you've described. We need a lot of either subject matter experts or a lot of follow through on that. So if you could talk with us, and I know you're going to talk about your budget priorities next, so maybe it's wrapped in, but if there's anything specific with regards to administering programs funded through the alcohol tax, I would really like to know as much as possible on how we can make that as successful as possible for the health department.
I can send you, we did work that out in this scenario in a previous presentation, I think in May, so I can go pull that, and I think that's still relevant. As we bring on resources, there are some resources that that we're bringing on that can be shared resources, right? So it's kind of the same line of long, bringing in homeless, expert program staff. You still, when you're doing large scale contracting and quality assurance of program delivery or service delivery, even though we're not providing the service, we have to provide the oversight and be accountable to the assembly and the administration that those dollars are being used well. We're hoping that we could find some efficiencies in the shared resources. So not necessarily bringing on an accountant for each line of business, but saying, okay, yes, we do need another accountant to make sure that we can do the finance part and another grant and contract person to oversee that piece. Well, can there be some shared efficiencies between the alcohol tax prevention delivery and the prevention money and the homelessness resources as well? So I can share you what we looked at, kind of a high level. And I think that sounds like right in the range of what we had recommended. Because what's even essential in addition to the contract staff is the program expertise, because we have great grants and contracts and great finance and accounting, but if you don't have somebody that really understands and can get up every day and make sure that we're holding programs and services accountable to the level of our statutes, codes, and expectations, then we're not necessarily doing our best job.
Thank you, and I'm really glad you wrapped in program expertise there at the end. That was going to be my follow-up. Thanks.
Great. Mr. Constant?
Yeah, thanks, Natasha. This is the first time somebody's proposed, like, looking at it from a percentage basis, and it's a very intriguing framework around looking at the issue. And one kind of thing that it lends its argument to is what Mr. Weddleton's been talking about, is waiting until next year forward funding so we have the cash so we can make determinations by percentage. Or we just have to set targets and hope we get there. And then I think that one way to look at what you just described, the cost of managing these programs, is maybe we ought to contemplate some form of like OEM that we add to bond projects, where every project that we fund, every line has a percentage allowable for administration and management. And maybe it could be higher for certain types of categories and lower for certain other types like grants. But it seems like if we're going to look at it from a percent basis, then we ought to contemplate figuring out the percent it would take to actually manage all these programs and then just bake it in from the start. So it's not a constant process of looking here, we need a little more of this, looking here, we need a little more of that, but instead provides the department with the flexibility they need to be able to effectively manage this pool of money.
Yeah, I think that would be welcome by our staff. It's, we work really hard to find efficiencies. I mean, you all know we're a really slim run organization, and when we ask for things, it feels like we're asking for too much. Like that's how starved the department has been for a decade or more. And we have grant staff who are trying to be program experts and accountants that are trying to, do things that they shouldn't have to do. So I welcome the administration and the assembly looking at an equitable way to bring resources into the department so that we can do a good job, because everybody here gets up every day and wants to do a good job, wants to be accountable, wants to be able to give you guys outcomes and reports, and we're not always able to do that in an efficient manner, so I support it.
Thanks, Director Pineda. Is that it from you, Mr. Constant?
Yeah, I just think we'd be wise to build in a mechanism for management as opposed to just leave it to some squishy method that we approach annually.
Yeah, I think that's an excellent point. And I had sort of assumed that the amounts we were funding would include administration of those amounts. But I thank Ms. Zalatel for bringing that up. And now you, Mr. Constant, and Ms. Pineda, because it's a really important point. And yeah, I appreciate the conversation too about percentages. It's interesting. I mean, given what we might get next year, we don't really know. So. Okay, I just want to give everyone a little heads up. We only have 9 minutes left, but we don't have a meeting after this. So it seems like we're having a pretty robust conversation, and we might go a few minutes over if that works for everyone. Natasha, you ready to move on to 3C?
Yes. Let me try to share my screen again. I just have 3 quick slides here, so it shouldn't be too in-depth. These are just, let's see, how do I share that? Okay, so here are our budget priorities. These are, you know, a no surprise to probably any of you or the administration.
Natasha,
oh yeah?
I think so you're doing budget priorities, or are you covering, oh, I see. So when it said AHD priorities, are you running through the budget?
Yeah, just high level idea, things that we think are important going forward. What were you thinking?
I think Suzanne and I were thinking that we would go through the report that the fellow did, Sarah Richardson, and talk about what of those priorities, like substantive priorities, we had accomplished or not. But if you're not prepared to talk about those.
You mean related to substance misuse?
Yeah, she did.
Oh yeah, I can pull that up.
Okay, that identified, I think, 5 top priorities for the Muni to implement best practices. One was the alcohol tax. So we did that, but there were others. And if you want to do that now, you can. You can circulate it. The idea was that as you're leaving, we just have some goals together that we could pursue after you're gone. But I would love to then, as we move down to the 4 items and talk about budget, you can present those priorities. And Suzanne also was prepared to talk about the committee's priorities as well.
They actually just recently sent me an update. So hold on, let me pull it open. I just happen to have it.
It's great.
Okay, let's see. Let me see if I can find this slide. That's good. I'm glad we had clarity here.
The agenda isn't super specific. Was someone trying to speak up?
Here, I can share this. Okay. So on the substance misuse assessment, let me just pull this. I haven't read it in a little bit, so but I think I can do it.
I think toward the end there were like 5 recommendations.
So these were the recommendations. There was there was 11 recommendations total. Enacting retail tax, not supporting increase of alcohol outlet sales, enacting a policy for Narcan distribution, the Tobacco 21 ordinance, investing in free or inexpensive extracurricular activities for youth, allocate funding for crisis stabilization. One was ours, which was implementing screening, brief intervention, and referral to treatment, supporting development of housing first options, pursue funding for a treatment center, require municipal language to be in line with recognized best practices, which you guys did, and requiring municipal employees to attend training on trauma and cultural competencies. So this is an update on that, this slide right here. We've done a kind of I'm really proud of the work that we've done here. I haven't updated this because we updated it prior to the alcohol tax being implemented. So this first one is completed. The second one, I just need to, it's been delivered, but hasn't been enacted. The remaining one would be investing in free and inexpensive curricular activities for youth, allocating funding for crisis stabilization, supporting housing first options, and then pursuing funding for a treatment center. But I think that one's actually almost accomplished. So we only have a couple left. So I'm happy to summarize those remaining ones and update this and give you guys a kind of a closeout. We have it for each one where it shows the life cycle of each one of those policies in this presentation. So if you want, I can clean this up and give it to you so you can review it. We've got one for each policy.
That would be great, Natasha. I think it'd be good to have, what we've accomplished and what's left as you leave, so we can really stay focused. And just want to thank everyone, all my colleagues, for all the work we have done. And of course, Natasha and her team. It's pretty incredible when you look back. Mr. Dunbar has a comment or a question.
Thank you. Ms. Pineda, could you remind us what exactly was meant by the crisis stabilization centers?
Let me pull it up. I can go find the exact language because I think we tried to keep it broad because what we were trying, and so I'm hoping we did, but I haven't looked at it in a while. There's a lack of substance misuse treatment options in Anchorage. So the 3 policies under that were to do the SBIRT here and the screening, brief intervention, referral to treatment here at the health department, support housing first, and then pursue funding for the treatment project. Oh, it's not in here. Okay, there's a lack of behavioral and psychiatric health services exacerbated by substance misuse crisis. You know what, Forrest, I'll print out the full statements because these are more like high level talking points in our report.
Well, can I ask, so Ms. Zolotel, Ms. Quinn Davidson, and myself are pursuing, mental health first responders. And I know that the model the city is looking at also looks to that kind of mental health crisis stabilization as a part of that, sort of as the third component to that. Is that what you're talking about here, or is this something distinct from that?
I think they're both in the same hemisphere of what you guys are trying to accomplish. And this was 2 years, this was 2 years ago. So the whole world looked different 2 years ago.
Sure.
But I believe she built them pretty broad, and each one of these policies has like a 2-page explanation. I just don't have it right in front of me, but I'm happy to share it. And then I think as you review them, keep in mind that, the universe has changed a little bit. But Sarah was pretty good at looking at things from a broad-based perspective. So I think everyone recognizes that there's an issue with crisis response generally, whatever that means at the time, right? So that might look different today than it did 4 years ago. And there's been a lack of accessible treatment for people with both mental illness, substance misuse, and traumatic brain injuries. So those were important things that were highlighted in here. So I'll reshare that with all of you along with an updated PowerPoint. I'll get this updated and have these cycles of the different policies updated to where they are today.
Great, thank you.
Excellent.
No problem.
Yeah, really helpful for us. Thanks so much. There are no other questions. I think we'll move on to 4. Before we do that, can I get a motion to extend maybe just for 10 minutes or so?
So moved.
Great. Anybody want a second? I don't know if we need that.
Second.
Great.
Okay, can I just confirm that that the Public Safety Committee's been canceled?
It's actually been moved to next week. So it's on the 12th, I believe, from 11 to 12:30. It's on our calendar. The next thing that we have today is the ADC luncheon, digital luncheon. It starts at 11:30, so we should be good. Okay, Natasha, did you want to go ahead? And I'm not sure if this presentation you have includes legislative priorities or just budget. I think we can sort of treat those together since they're often interrelated. You go ahead, and then if Suzanne has comments, we'll add those.
Yeah, I can just talk through it. So what we're looking for, and I know that these are things the administration's already aware of, is that, the funding necessary to maintain some critical positions that have been brought on to address homelessness program support, community health nursing, and those are time limited. The community health nursing one is time limited to COVID, but since this is going to be seems to be a marathon, not a short race, that it would be really important for that to continue to be supported. And then the department-wide epidemiologist is, I think, critical to have long-term investment in. We plan on having that person go after funding to pay for themselves, but in the space where that doesn't happen or funding dries up, it's just really going to be critical. You guys can see what happens when you don't have a data scientist at a local health department. It makes it very difficult to get real-time active information. So that's important to us.
Natasha, are you going through slides right now? Could you share them?
Oh, yeah.
Thanks.
Sorry. Can you see that?
Yes.
Yeah, okay. And then another ask that we have in, and I think we always ask, but we've never, I mean, one of the things that we've done as a department is to make really comprehensive budget overviews of what we wish we could have. We recognize that we can't have all these things, but we think that after 30 years of trying to move, buy a different building or do something different, that a lot of, our leadership team here believe it would just make a lot of sense to go ahead and start the capital improvements to slowly rebuild this building to a standard that would be useful. It's got great square footage. It's in a great location. So initially we'd love to have the boiler replaced and the first floor and the second floor remodeled to make more efficiencies. We have for any of you who've been in here, we have really big wide spaces that could be used differently, and we could have more office spaces and a better clinic setup. So that's just a hope, a wish we could have. We've laid that out pretty clearly. In the past, about I think 12 years ago, there was a proposal to replace all the windows in the building. And then they started on looking for another building again. And there's just been a long history of that. So our staff are saying, can we just go ahead and start fixing this building? The other requests that you'll see come across at some point, either this year, next year, or the future years, we'll always be asking for compensation alignments. In particular, last year we looked at WIC. This year, it's become really obvious to us that some of our public health nurses are paid at a rate that should be adjusted based on what's happening in the market. We always have contractual obligations. I think this year it's just animal care and control. And then we are in great need of IT infrastructure investments, but we'll ask for that. We'll just keep asking for that. And then obviously the right sizing of our department. So there's always pretty clear requests that we're going to be always putting through each year that will line out what a right-sized department would look like and what kind of employees they would have to ensure quality improvement and quality training is happening for our staff. But we all, again, recognize that there's a lot of budget priorities. So I just wanted to share with you what our leadership team thinks is important. And that's it.
Great. Natasha, would you mind just moving to the first slide since we didn't actually see that one? And then if there are any questions,
oh yeah,
we can be looking at that. Ms. LaFrance, I don't see any questions. Oh, Ms. Salatel, go ahead.
Thank you, Madam Chair. So I'm really excited for the new work the municipality is taking on. Of course, I caveat that with we maybe wouldn't have to if the state would do it or do it in more comprehensively, specifically around mental health and some homelessness. So I'm curious on the implementation side. We're really bringing on a set of services that haven't existed within the municipality to this extent. Should AO 2020-66 pass, we'll be overseeing at least the contract for a substance misuse treatment center, a shelter, and a transitional housing. I'm wondering how that's going to live within the department and what we can do to support that work so that it's robust, because I think all eyes will be on it, and we're going to want to move forward, at some significantly high standards for that work to be done.
Yeah, so I'm happy to talk about that. You're right with the kinds of programs that we're going to be delivering. It's going to be a new way of oversight. About 10 years ago, there used to be pretty comprehensive homelessness programs at the health department, and over time, those were changed and modified and cut programs with new administrations and resources removed. So we are putting together, we've put together a proposed suite of staff to oversee, and as you guys know, we have to put in a manager, you have to have a supervisor, and staff program support to do that, but also the contract and finance support. So because these will be primarily contracts and we work well in that environment as an organization, the health department has been very successful in managing large scale contracts like animal control, like the Anchorage Safety Patrol and others. that have both a programmatic aspect. So we're basically building off of that ability and putting together what we think is the right set of staff, contract and finance folks to be able to support those programs moving forward. The area that I think will continue to have some weakness in is behavioral health, as that has for over 20 years sat directly with the state of Alaska, and it will require quite a bit of coordination. And I think about something for you guys to think about, because I won't, be here to do it, but I think we've got some really able staff that are really engaged, is that the reason COVID response has actually gone as well as it has, in my mind, is because of the decade-long relationships that we have with state EPI and the state public health department. We rely on those daily. Before COVID, we were in regular communication with them. And what we don't have is that regular communication with behavioral health. We have contacts, but not the same level of engagement. So that's going to be something that you really have to think about as you put together your programs and think about how you want to scale them up as an as an assembly and as this administration moves forward. But for now, we have what we think are the right array of staff for the proposed projects and for the sustaining of the long-term sheltering needs that exist outside of that. Because as you know, basically, prior to the emergency, Nicole Lebo and myself pretty much managed the homeless contracts and staff and outreach. We don't have staff to do that. So this is going to be really important.
Thank you.
Thank you. Ms. LaFrance, did you want to add any comments before we move to audience participation?
Thank you, Madam Chair. Just wanted to mention that back in May, when you and I had put together the budget priorities for the committee, I mean, it goes without saying that things were very different even 2 months ago. And we structured the priorities around those 4 assembly pillars of public safety, homelessness, quality of life, and economic development. And our first priority was to maintain the continuation budget and to fund critical positions. And I understand from our conversations about the CARES Act funding last week that, for example, an epidemiologist is proposed to be funded at least initially with CARES Act money. And with these intersections and overlays of CARES Act money and alcohol tax revenues, definitely there's a unique situation. And we had stated in previous meetings our support for an epidemiologist, a senior office associate, and also for the public health nurses' compensation, as those salaries and wages are below market value, and as well as our support for capital improvements for the building. Though I think it would be helpful to get an update at some point on the status of the proposed new building project. And given that there are so many pieces in play and that the scope of the proposals concerning just the alcohol tax, as Member Zolotel and others have noted, will have a huge impact on staffing and structure, even perhaps, of the department, I think we'll need to revisit this list of priorities as CARES Act money and alcohol tax proposals come into clearer focus. I'll leave it at that because I know there's just 1 minute left and you may have folks who want to speak. Thanks.
Thanks, Ms. LaFrance. I really appreciate that. Yeah, it looks like we have 2 numbers that I don't recognize. If either of those phone numbers, either ending in 834, I guess we'll start with 8345. Would you like to participate in audience participation? We only have a minute or so. Please press *6 if you'd like to speak. Not hearing from 8345, we'll move on to 9449. Please press *6 if you'd like to speak. Okay, I'm not hearing from anyone. Before we adjourn, I just want to thank Director Pineda. It's really sad to see her go. She's been just an incredible force. Yeah, it makes me teary-eyed just thinking about it, but we just so appreciate your dedication and hard work and how you've handled this pandemic with humor and grace and just held it all together and carried us with you. So thank you for making our city better. We'll miss you.
Thank you. Thank you guys for creating a committee that focuses on health. And it's been, I think, really changed the way our department works with the assembly. And it's meant a lot to the staff. And I really appreciate everything that you guys are doing out there. Thank you.
Absolutely. Does anyone have any closing comments before we adjourn?
Thank you, Natasha. Just want to echo what Ms. Quinn Davidson has said. It's been wonderful working with you and just so grateful for all your support and for being policy and data driven. Thanks.
Hello? Hello?
Sounds like we have someone in the background, but unfortunately we've run out of time. Is someone trying to give audience participation?
Yeah, it's Eugene.
Okay, Eugene,
Hello?
we'll give you a minute and then we'll just have to adjourn.
I'll be very brief. My name is Eugene Carl Haberman. I represent myself. I follow the public process. When the public process is done, appropriate decision made by the governing body is more like the public interest. Number one is, I listened to the entire meeting. Number one, your presentations were not available online on your committee, health committee. The agenda was there, but to follow the presentations and what was said here, the public could not see. Now you're going to say more likely after I say these words, we need to put it on the website, get it on the website, but it's too late when you do it in a way that the public cannot follow what you're doing. And of all things, you're dealing with a COVID issue, and you need to address that. And now in closing this, the last assembly meeting, you created final audience participation. You called one person, no one answered, and then tried anyone else. I was one of the people that signed up for that. Unfortunately, the comments I wanted to address were factors that affect you and the community and the state dealing with the COVID issue, and particularly what's going out in the valley, the irresponsible Wild Wild West that's affecting Anchorage because of the. And so I'll address it, and I'll sign up for the next meeting Tuesday, and I hope you connect with those people who signed up respectively. Thank you very much.
Thank you, Mr. Haberman. And it's a good reminder to get presentations up in advance as much as we can. We really do try. We know that Director Pineda was probably working on this last night to have it ready for us. The chairs hadn't seen it either. So appreciate the comment, and we just continue to do our best. And Carissa, can you coordinate offline with Natasha to get all of these slides and get them up on the website?
Yes, I will.
Excellent. With that, I'll entertain a motion to adjourn.
So moved.
Okay, excellent. Bye, everyone.